Hi, everybody. This is Erica Mello, and welcome to podcast episode number 64. And this is an interesting patient of mine. He's not the typical persistent chronic type of patient that I do see, but he came in to see me with some issues with regards to his glutes and his anterior thigh. And Susan and I really talk about differentially diagnosing pelvis versus hip versus lumbar spine, and we go through my evaluation and some really great treatment ideas to really make a true diagnosis of this man's problem. So I hope you enjoy it, and thanks again. Hi, everybody. This is Erica Mello with my wonderful co-host, Susan Clinton, and we are tough to treat. How are you, Susan?
I'm good, Erica. How are you today?
I am good. Good. I just came back from our Graham sessions in Nashville, and I'd never been to Nashville, so it was nice. It was nice just to get away for a couple of days, and no snow, no flight delays. Thank God. So it was nice. So should I get right to it?
Let's get right to it.
Okay, let's see. This is a gentleman I'm actually still treating. I've only seen him 3 times. So I would appreciate your thoughts on what you think his issue is and maybe some steps going forward, because I'm torn between 2 things, so I'll sort of start off. He's 72 years old. He came in to see me with complaints of right glute pain into his anterior thigh. And when he said right glute pain, he was just really just pointing like right to the middle of his glutes, a little bit down on the ischial tuberosity, but mostly just glute, not back pain. He does have a history of back issues. I've never treated him for them, but that was his relevant past medical history. What most aggravated him was sitting and driving. He had no numbness, no pins and needles, no weakness, no bowel or bladder. He said ibuprofen made him feel better. This was a sort of an acute issue. It started literally just a few days before, or about a week before I saw him. And he also added that sitting and sort of crossing his leg, like bringing that right hip up into flexion, external rotation to tie his shoes, also bothered him. So sitting, driving, and then just a little bit of hip flexion with external rotation, like he's going to cross his legs. He sees a trainer twice a week, and I'll get into that in 2 seconds. The only other thing that made him feel better, I think I said, was ibuprofen. He said lying, like sleeping on his right side, also was aggravating. No imaging. He felt better in the morning. And I'm thinking, okay, right side lying aggravates him, maybe hip. So automatically I'm like, I cannot think that, because, a lot of people have hip issues and they, or back issues, and they lie on that side and it bothers them. His general health, he basically had a little bit of reflux. He was on some PP, protein pump inhibitors, statin, Proscar, and just took some vitamins, etc. So that was really it. Nothing of significance. So he saw the trainer twice a week, and the week before this issue came on, he was actually having left-sided low back issues. So his trainer started to stretch him out, and he said, I think that was it. He was a little bit aggressive on both sides, so left and right. So his left side of his low back and his right side of his low back, his right side of his hip and his thigh started hurting after that stretching episode. He also he said, I rolled out and laid on a massage ball over the weekend, and I think that made it worse. He likes to walk. He cycles to work. He has not cycled, obviously, since sitting actually bothers him. Took about 1 minute. So 1 minute pretty quickly to flare his symptoms up. And he was somewhat irritated at the time I saw him. And that's basically his relevant medical history. Do you have any questions about anything so far?
The only question I have is, when he was sitting to cross his legs to put his shoe on, is he crossing his leg over the leg, or is he crossing it like the letter 4?
Cross it like the letter 4.
Okay.
Yeah. Yeah. Like exactly like the letter 4 to put on his to tie his shoe. So it
Okay.
wasn't up, it was more crossing. Exactly. Not crossing like you're sitting, but crossing to actually into external rotation.
And when he's standing and walking, no problems?
No problems. Yeah.
So it feels better as soon as he stands up?
Yes.
Okay. How long
Yeah.
does it take for it to feel better as soon as he stands up?
Probably about 5 minutes. So
Okay.
1 minute to turn on in sitting, about 5 minutes to ease in standing.
Okay. And what
Yeah.
about stairs?
He had no problem with stairs. He doesn't do
Going,
stairs. Yeah. So, but no problem with stairs. He doesn't
no
do
problem
stairs.
going upstairs.
No,
Okay.
no. I asked that. Yeah. But he doesn't do stairs a lot, Susan, to be honest. He's a lawyer. He works on the 60th floor of a building,
Mm-hmm.
doesn't take subways much. I think he takes cabs and Ubers here in New York. So doesn't do stairs. Like when I
Okay.
had my hip issue, stairs bothered me.
Mm-hmm.
Didn't really bother him. It was really the sitting.
Mm-hmm.
So when I had him in standing, I'll go through this sort of somewhat quickly, but the obvious thing I saw, because I've never seen him before, was this right pelvic shift. His center of mass was to the right. And I thought to myself, well, maybe, he had a left-sided low back issue the week before. Maybe he offloaded that. I don't know. I don't know if that's his preferred standing pattern. I've never seen him. And then the one thing that I did notice is he was really on the right leg and just definitely in that transverse plane rotation to the left. Makes sense. On the right leg, he sort of rotated to that left side. And so then I just put my hands, I like to sort of put my hands on the top of the pelvis. I close my eyes and I just kind of intuitively, put my hands on a person and just feel. I know it sounds, no mechanics, nothing. I just put my hands on him. And I just felt like this shifting back and forth in his pelvis, like he was going right, he was going left. And it was just, and I don't usually do that as much, but he was more of this acute issue. He was really on the right leg, and something just told me to do that. And so it was back and forth, right, left, back. And I'm like, well, this is the nervous system trying to figure something out. And I just wrote that down and moved on. I had him do the lumbar bend over, forward bend. He did get 2 symptoms there. He said pulling in his right glute, nothing in the thigh. And he said he had some he was able to go to about mid shin before the glute symptoms set in, but no anterior thigh pain. Then what I did was I just said, since you have a problem sitting, show me how you squat, show me how you sit. And he squatted, he sat, he literally was shifted way over to the right. The same thing. He also had this medial compression of his hip. So what I did was I just got to the right side of him. I put my left hand on top of his iliac crest, my right hand around the inguinal fold area. I had him squat and I felt like this pulling of the like a medial compression of the right hip, and it wasn't painful. Squatting was not painful to him.
Mm-hmm.
So, but if I did a few, I think it would have been. I ended up deciding to correct the rotation in the hip, and I had him squat. He still was getting the medial compression in the hip. So then,
So was he able to squat fully, or was this only a partial squat?
he was able to squat as low as he could go without getting his heels off the ground. I put him on a half foam roller and had him squat again, and of course he went much lower on
Okay.
the half foam roller.
Okay.
So
His back was straight?
yep.
Okay. Mm-hmm.
And so I got him on the table at that point, and I did a slump test. And so from a neural tension standpoint, I believe it was negative. The only issue that I got with a slump when he did the right knee extension, he was kicking all of these interior thigh muscles in, rectus, quad, adductor. I said, I was trying to differentiate with leg, dorsiflexion, plantar flexion, cervical spine extension, flexion, slump made no difference in terms of that upper thigh ache. So I think that was just because he was sitting and he was extending that right leg out like he was driving, because driving bothers him, and he was just getting all this increased muscle tone in the front of his thigh. So from a slump tension standpoint, that was negative for me. I did have him lie on his back. Oh, excuse me. I'm going to backtrack. I had him stand and do a open kinetic chain hip flexion as well. and that did aggravate him. Okay. So what I did is I tried to decompress the hip a little bit. It's very hard to do that in open chain flexion. I got on his sit bone and I tried to sort of lift it up a bit from the back and then decompress with so he's on his right side. I took my left hand under his sit bone, sort of gave him a little bit of a pullback, so to speak, and I took my right hand on his right sort of upper thigh to do a little bit of decompression. When he did that hip flexion, that was hard, but he said it did feel better, and that's hard to do that type of correction in standing. So after I got him on the table, I did the slump test. Then I had him lie down. I did a straight leg raise, and his glute symptoms kicked in around 70 degrees.
Yep.
Okay.
Yep.
And then I said, just do an actor straight leg raise. Just let me see what your strategy is. And he kicked in, with that right quad. Once again, same symptom, reproduction. So then I checked him I checked his hip flexion. Left side was good, right side was 90. So left side was probably about 110, 105. Right side was about 90 degrees and like a sort of a hard end feel. I turned him over and then I did some just passive accessory vertebral mobility testing because I wasn't sure at this point. Back, hip, I was really sort of trying to confirm a diagnosis, and it was all normal. No, I didn't reproduce anything, and I went central, bilateral, transverse process, nothing, zero, no symptoms, nothing. The only issue I saw in terms of muscle tone was in the front of his hip, psoas and rectus femoris. He had no increased tone in his back. None of those provocative pivums, pavums, they did not reproduce anything. In prone, I checked his hip in prone. His external rotation was greater than within. I mean, it was, I think, he obviously was sat as a child with, crossing his legs because is completely hypermobile, both legs into external rotation. His right hip was a little bit more hypomobile into internal rotation. And I tested this prone. So I will stop there and you let me know what I did one more thing. Hold on. This was the kicker for me. I got him on all fours. I said, just, I didn't tell him to go into neutral, flexion, extension. I got him into all fours. I said, just do a sit back. Your knees about hips width apart. Just sit back onto your heels. And he got it in the butt with that as well. So I'm going to stop and you let me know what your thoughts are.
So, trying to differentiate between hip and back at this point, because certainly hip joint pain is anterior thigh and posterior, right at that glute spot can be a hip. Could also be some nerve irritation as well. I find it interesting that the slump test in sitting was going to be bad because he can't sit.
Right, exactly.
So, but I like the fact that you did the straight leg raise test because at 70 degrees he started having symptoms.
Yep.
Which means that he can sit as long as his hip is less than 70 degrees.
Exactly.
So if he could sit at 60 degrees or 50 degrees, that would be better for him because he wouldn't have the symptoms.
Yes.
It also keeps his back straight.
Yes.
So you don't have the issue of the back. Is it flexed or is it not? But you're really pulling on the, with the straight leg raise, you're really kind of pulling on the nerve there.
Yes.
So that's why we have those dural tests in both positions, not just in sitting.
Yep.
And then, of course, as he goes to flex his hip in standing in open chain, then he's going to have some back flexion that occurs with that.
Yep.
As well. So 72, it's not unheard of that he could be having probably some stuff with both. It sounds like he's, avoiding close pack position on the right. But when he's put into close pack position, he doesn't do as well. But he didn't have symptoms when you had him in extension, although he just didn't have the internal rotation, right?
Right, correct. What was interesting to me is that even when I have patients who have a hip issue, I mean, yes, he was a little bit more acute than the common person that I see, the typical person I see, the typical patient. Usually if you have a back issue, you can generally get back onto your heels without any symptoms. At least that's my experience. And the minute he went back, he felt it in the butt. And I was like, usually people with back issues can do that a little bit, but not him.
Well, he's so acute, I'm beginning to think that flexion is just a no
No,
for him. He
no
just
bueno.
can't do
Yeah.
it. Yeah, he can't do bendovers. He can't, he can do squats somewhat because his back is straight.
Yep.
But that's a little bit different. So, it's kind of like, is it walking like a duck and talking like a duck? Is it really a duck? But what did you do a hip eval?
What
Did
do you
you
mean? Like,
do like, Faber and
yes. Yeah.
compression and scour and
I didn't do a scour. I did, I,
distraction and stuff like that with him
yes.
laying on his back?
So I know I did that in standing. I distracted him in standing, actually, when he did the hip flexion. I did the Faber. That was positive. So he
Okay.
couldn't, he actually did it himself. He couldn't even do it. So that was positive. I didn't do the scour. I went into hip flexion, internal rotation a little bit. That he had 0. So when I had him on in supine in hip flexion of 90 and tried to do a little bit of adduction, I got nowhere because he had no range of motion. I tried to do a little internal rotation in that position and then adduct. I was just, there was no mobility at all
Did
there.
he have pain? Did it reproduce
No,
his pain?
he
Okay.
did
All
not
right.
have pain. Yeah.
Okay. All
Yeah,
right.
the
So,
only thing that reproduced it was that figure 4, that Faber test
and where did he have pain with that test?
in the glute.
Okay. So, um, yeah. And, 72-year-old gentleman, this could be, something that has, especially if he had that aggressive stretching, it sounds like maybe something irritated the nerve roots.
Right.
And not enough to go all the way down the leg and, give him all the other stuff. It's fairly acute, but it could be that he also probably may have had some irritation to his SI joint. It's not unusual in a 72-year-old that doesn't have a lot of closed packing in the hip. I mean, if he's been somebody who's got a retroverted hips on both sides, which it sounds like,
Yep.
he's going to have some decreased closed packing when he, with all the walking and the biking. He bikes a lot.
Mm-hmm.
So, when you don't have closed packing in the hip and you've got some limited motion in the lumbar spine, when you're 72, your SI joint may begin to start taking a little bit of a beating,
Mm-hmm.
and that could be maybe one of the sources that's kind of bugging him. And that's why when you do the Faber, it hurts in the underside
Yeah.
of him rather than into the front of the hip.
Yeah.
And it's interesting that when you do the hip stuff, you find limited motion, but it doesn't recreate his pain.
No, it's like it's the combo lumbar
Mm-hmm.
hip motions.
Yeah.
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 That get him.
So his,
Yeah.
so it could be, it could be neural. It could be that bit of the SI joint being a little bit, kind of irritated at this point. That would be my vote at this point.
Yeah.
Until proven otherwise. I wonder what a thigh thrust test would reveal on him, if that would reproduce his pain too. It's really hard to do, though.
It is. I tried that the second visit. I actually tried to put him in Diane Lee's compressor belt just to see if any stability there with any compression patterns. I did do that, and it didn't really help. I actually tried that in the all force position because that actually was the one that was getting him the most at that point, and that didn't help. So I often think when I do the straight leg raise, usually he's like, do you think I have a disc? I'm like, no, I'm like, no, I don't think you do. So number one, people with really hot discs, they can't go much. I mean, at 70 degrees of hip flexion,
Yeah.
they're feeling it way before.
That's why I'm
okay?
saying more and more into SI.
Yes, I agree.
For him, just because, again, 72, loss of closed packing, you got to get the extension somewhere.
Mm-hmm.
He just could be having a little bit of some irritation to that SI joint, and it's gotten really acute. I don't find the belts help much in that.
Yeah.
I just don't find that they do. The compression bothers them.
Yeah, exactly, which is what I
And
wanted
that's
to
what's
confirm.
happening when he lays on his side. It hurts him.
Yeah.
If he lays on the other side, it feels better.
Yep.
So that would be my vote at this point until I know otherwise. But it would be interesting to see what would happen if you could get him moving in some other directions to see if you could relieve, the thing there. It's I wish people wouldn't take somebody who's somewhat maybe a little bit on the stiff side and like overstretch them.
I know.
There's so many better ways to gain mobility for folks without overstretching. I just think that he just got, he just got that side loaded in a bad thing, and it just kind of like shot off something there for him.
Yep. Yep.
Wow.
What's
Yeah.
What's interesting is too, because with the lumbar forward bend and the all fours, yes, you've got lumbar flexion, and that did set it off, but the squat didn't, because he's pretty,
He's straight. Yes.
he's straight.
His back is straight. He's okay. Yeah.
I did think also with the straight leg raise at 70, I'm like, this has got to be some SI joint or pelvis. I'd also thought that when I did that, and he was like, and so then I had him do an active straight leg raise. I'm like, I'm just looking at your strategy. Don't get concerned about
Mm-hmm.
anything. And he was fine with that because he's had PT before. It's not like this is his first rodeo here.
Mm-hmm.
So what I did was, in that first visit, I basically told him no stretching. I always tell patients a lot of times it's what you need to avoid that's going to get you better quicker in a way. So I said, no rolling on the ball, no stretching. I got him sit. I said, you need to sit with a bit of a lumbar support, because he was going to court. He's a lawyer. He was going to court the next day for arbitration. He was going to sit for 5 hours. So I said, do you have a book, a pillow, anything just to give yourself some support? And I said, you need to sit in a higher chair. You can't sit in a low chair. Like sitting on a toilet bothered him. I'm like, that makes
Mm-hmm.
sense. It's much lower than you almost need to be in a bar stool. And he's like, well, I can't do that. So anyway, so I gave him that. I did treat him a little bit. I did try to I mobilized the hip a bit with the belt to see if I could get a little distraction there.
Mm-hmm.
And that did help. The thing I gave him besides the lumbar support, I had him do the wall squats. I had him face the wall, put his hands on the wall, equalize the center of mass, and just squat, because that was the only thing that didn't bother him. Just to do basic squats. Go down, squat, see if you can go as low as you can without hip pain. So that is what I sent him home with the first visit.
Mm-hmm.
And
So
then
I'm just wondering, through all of your testing, did you look to see if his he got worse with bendovers and with sitting? Did he do better in prone?
he did better in prone. I had him go up on his elbows.
Okay, and prone on elbows was not painful?
No.
Okay, and no centralized back pain?
No.
Okay, so he was okay in extension.
Yes.
But along with hip extension.
I didn't test hip extension. You
mean
hip extension?
I mean, if you're pushing him up on his elbows, he's essentially, he's going into back extension, hip extension a bit there.
Yeah. I didn't test hip extension on its own, but yes, correct. I did do that.
So did you do standing extension?
No, I did not.
I'm wondering if that would, as soon as he stands up, if that would help relieve his symptoms faster.
It probably would. I had him do, so after the all fours, he was a bit flared up. So I said, just do some squats for me, because I had just had him squat. And he did, and he actually felt better. So I was like, yeah, I made a decision. I'm like, I don't really need to test anything else. At this point, because he was acute and flared, I was like, I don't really need to flex him anymore. I don't need to do this. So he felt better with it, with the squat. So that's sort of the first type of visit, because I was trying to distinguish between nerve, back, SI, hip, because he did have significant hip dysfunction, but it was not painful except when he did that figure 4 position. So I said to myself, I just have to put that in the back of my brain. He's, all of a sudden, he didn't get limited hip range of motion overnight. He's had this for a while, and yes, he's probably compensating. But I said, I don't necessarily think that could be the cause of the problem. But I did mobilize him just to see if I could get any change. But the biggest change, so he came back for the second visit. So I've seen him 3 times. So this was the second visit. He sat for 3.5 hours at his arbitration the next day. He put a hard book behind his back, and he said that actually was very helpful for him. And he said that sitting was a bit better, and he was able to lift his leg easier, like as in hip flexion. And I tested his forward bend, and he was able to go further before the glute symptoms set in on the second visit. So I'll fast forward. So what I ended up
before you fast forward, one more question from my point of view. Did you do a single leg stance on him?
No.
Okay. And did he walk? Did you see him walk? I
had him walk. Yeah, that's the first thing I do.
Any Trendelenburg or any lurching or anything at all?
No, no. I had him
Okay.
do a gait. I had him walk back and forth. I had him do big steps and a little bit of a lurch, but nothing crazy at all. You know, he because his sitting was the issue, I tend to go with like looking at the squat, looking at the forward bend, and if I'm not
Mhm.
getting anywhere, I'll sort of, you know, move do other functional testing. But because walking was okay, I said I don't need to do single leg stands. I can at some point, but the time was the issue in the first visit. So I wanted just to gather as much information as I could, just to give him like the what can't you do tomorrow when you're in your arbitration for 4
Mhm.
hours. So
Mhm.
the second visit, he once again he was feeling better. The hard book was helpful. I didn't recheck anything else. I rechecked his squat a little bit, and that was pretty okay. What we ended up doing a lot of the second visit, I did do some manual work with him. I ended up going and just releasing a bit of his psoas. I did not touch his back at all. I didn't do any mobility. I did no manual therapy to his back at all. I actually did some release work on his psoas. It was really very sore on him. Not that that's you know, relevant, but I tend to kind of go there with some of these patients. I mobilized the hip again. I did check his hip extension in side lying this time. Okay, and it was somewhat limited.
Mhm.
Then I had him, we worked on doing some weight shifting. We worked on squatting with the heels elevated. I review the wall squats again against the wall. Then we worked on sitting and driving postures. I rechecked the slump to see if, you know, if that was any different. It was a bit better, but nothing, you know, crazy.
Mhm.
I did not recheck the straight leg raise the second visit. Looking back on it, I probably should have, but I did not. Any questions after that?
Well, the straight leg raise probably would be better because the bend over was a little bit better.
Right.
No, I'm still saying that, you know, the SI got irritated, and it sounds like all the things you're doing was great. And it doesn't surprise me a bit that he lacked hip extension.
Yeah.
Like I said, you know, this guy sits all day long. He cycles to work. He's in that position all the time. And so he's going to lack, you know, that hip extension, internal rotation. So he's lacking some close packing. I don't think his hip is the problem, but I do think that the lack of motion at the hip might have been driving the SI a little bit
Yes, I
on that
agree.
side. And so when they overstretched him and did this stuff, you know, it just, you know, got irritated because
Yep.
it's probably trying to move a little bit more than it really needs to. I mean, the SI doesn't move that much. So, but, you know, even just a little bit of extra, you know, pull in that area, you know, could have been enough to just set it off.
Yeah. He's not the first patient that I've seen
This is
that,
not an unusual presentation
yeah,
that I see in,
yeah,
gentlemen of this age.
yeah, and it's like I was gonna say he's not the first person I've seen who's gotten worse when a trainer stretches them. I was like,
Hmm.
they just don't get it. I mean, sometimes you just can't aggressively stretch some of these older people, you know, and uh,
They do it to younger people too. So,
I know. I trust me, I know. So anyway, here's the kicker. He comes in for the third. So he basically went to see his trainer the next day. I said, this is what you really should not do. And I was telling him to do a lot of upper body. I wouldn't do a lot of things sitting. You know, if you want to
yeah.
do some, you know, some squats, that's great. She needs to monitor you, make sure you're not shifting your weight over, things like that. So what does she do? So he comes in the third visit, which is the last time I saw him. He said he worked out with his trainer. They did some upper extremity work, and then they did a couple of other things, and he felt much worse after. And I'm like, what did you do? So I'm going to start. So he said, however, my sitting is better. I'm like, okay, then why do you feel worse? You know what she had him do? She had him do these monster walks. He gets on all fours, and then he starts doing like hip flexion, you know, like on all fours. I forgot what they're
Hmm.
called.
Hmm.
Um, and he's on his hands and knees just
Yeah. The
doing hip
monster
flexion.
crawls. Hmm.
Yeah, monster crawls. I'm like, are you kidding me? I was like, that's on all fours. That is the one position that aggravated him. And
Hmm.
I always have to like stop and say, just calm down, Eric. It's not his fault, you know? And I
Hmm.
said, that's why you're worse. And he knew it. He's like, I knew the minute I did that, I shouldn't have done it. I was like, she should have known that.
It's okay.
Anyway.
Test and retest, live and learn. Now he knows. So,
Oh, that's his test, actually. His all fours. I gave him that as a self
mhm.
check. I said, that's your check. You
And that's
know?
the position of being on the bike.
Yes. Yeah, sitting. I said, it's the mirror image of sitting. You think about it, just mirror image,
Mm-hmm.
and he's like, oh, you're right. And then but interestingly enough, I checked his lumbar forward bend. It was fine.
Mm-hmm.
So then I got him on all fours. I said, let's just check this now. It was like 24 hours post trainer workout. And he felt it immediately in the glute. I said, let's go into a little bit of extension. You just say, drop your butt. Just give me a little bit of an arch in your back and just go onto your heels. He said, oh, I feel better with that. And then I said to myself, I could flex them, but it'll really flare him up. And I just tried a little bit. I said, just do like a real round your back and sit back onto your heels. He's like, that's worse. I'm like, okay, there we go. Okay.
Mm-hmm.
So I basically added to his program. I said, you need to do, he obviously likes, in that position, he likes extension. He likes to, sitting in extension with his hip flexed. So I actually gave him that as an exercise to do. Just, in a little bit of extension, go into all fours, continuing with the squats. What I ended up doing this session, I worked on a lot of his because he was seeing the trainer again, and I was like, you cannot do these exercises at all on these heavy resistance on all fours. As if you want to do a leg press, you can, but you need to be able to keep your hip at a certain range of hip flexion. It will flare you up. I would not do leg extensions. You can definitely do your squats. So in that particular visit, I repeated some of the things I had done before, but I really focused on, which is the belt and a little bit of the psoas work. I did some distraction to the hip with straight leg raise and distracting, that type of thing, similar to what we discussed in our last podcast that you did with that woman on the boat, where you.
Mm-hmm.
So I literally was just sort of doing a straight leg raise with distraction. I did that a little bit. I got him on all fours and extension. I tried to train the mirror image of sitting on all fours. Like, just get yourself an extension. Let's put you in a seated posture, but on all fours, and just train that movement. And he was able to do that. Then I started focusing a little bit more on squatting, just keeping his back and more of and obviously without flexing and extension, still heels elevated. And he had really no problems with that. And I told him
Mm-hmm.
that his self-check is going to be either open kinetic chin hip flexion or all fours, because all fours gets him immediately.
Mm-hmm.
And his reset would be squats. And so
Mm-hmm.
that's where I've left him. That was last week, actually. So let me know your thoughts, maybe what you would do next visit, things like that.
So he was sitting comfortably?
He said he was sitting much better. So
Okay.
he
But was
still
he sitting
felt it.
comfortably?
What do you mean?
Much better, but was he still having some pain, some
Well, that's what
issues?
he was able to sit for longer periods, but he still had to get up. But he said it was,
Yeah.
he was sitting for longer periods of time, then he had to get up. But for him, he's like, oh, much better. I'm like, well, what do you mean much better? I'm like, tell me. So that was it. He could
Right. So
tolerate sitting more.
yeah, I would just probably dose that a little bit more.
Yeah.
Like, don't let it get to the point to where you have to get up, but get up every hour and do some of these exercises and movements. I would just check and see when when he's having pain, if he can stand up and do trunk extension and see if that settles it down. It may not. I have no idea. I'm just thinking that might be another thing that he can do, where he can go put his arms up on the door jamb, and just stretch upward, to get out of that flex position. I would just head him more into how can he get some more, extension stuff and get the hip going a little bit more, so that, he doesn't have, so the back and the pelvis don't have to take up what the hip isn't doing.
Exactly.
Is where I would kind of head with him. It sounds like things have calmed down. Whenever he's not at work, perhaps maybe sitting on a taller chair or something, to just give him a break from that deep flexion.
Mm-hmm.
And, but I would work with just seeing if you can just get that hip moving a little bit more, so that, like I said, his back and pelvis don't have to take up the lack of extension.
Yeah.
That he's
That's what
got
I
in the
thought.
hip, so that he can get a little bit more close packing in there, and because he has to walk. It's New York, and everybody needs to walk anyway. But doesn't and that kind of motion doesn't hurt him. It doesn't give him pain, so it's a kind of an easy thing to work on a bit. You could even do it in lunges, half kneeling with the left knee up.
Yep.
and the right knee down. I mean, there's a lot of ways you can go with that.
Yep.
I still would be interested to see how he's handling and coping with step ups and step downs.
Mm-hmm.
You know, I'm wondering how much of this may have been driven by, you know, some changes in the glute med or in the lateral hip muscles at all. You know, especially if he's lacking full extension on that side. I don't know. I have
Yeah.
no idea, but it would be kind of kind of be some fun testing that out a little bit with him and seeing how he copes right and left, and if he can, you know, if he's got
Mm-hmm.
good, you know, easy movement, or if he's, you know, got a, you know, struggling a little bit on that, because those are easy things for him to start
Yeah.
doing too.
Yeah. Yeah.
It'd be
Yeah.
fun.
It's interesting because he definitely does. Um, he was like, should I bike to work? I'm like, no, you shouldn't bike to work right now. I mean, and
Not right now. Let's get this settled down, and then,
totally.
you know,
And
and then when you know the rules now, when you get off your bike, he needs to have a few things to do.
correct. And
You
I
know, to
said,
just kind of like change the posture, change positions, change things, so he doesn't just stay flex, 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 flex
totally.
all the live long day.
Yeah.
Yeah.
And I said, you can do lunges, you want to get that focus on each side, but because he wanted to do lower body. And I was like, well, you can do lunges. I mean, the thing that sort of flared you up was doing those monster walks. There's
Mm-hmm.
absolutely, I will tell you, I mean, and you were getting better, and whatever, I didn't want to belabor the trainer stuff, but he understood that. So I think
Mm-hmm.
that at the end, I think I'm seeing him this week, and he's actually flying next week too. He's got to sit on a
Mm-hmm.
plane. So I will actually check to see. He was driving this week, and I will check to see how his standing extension, see how long that takes to dissipate his
Mm-hmm.
symptoms in sitting. In terms of I was just going to say something. I do agree with you, which is why I went for the hip, because I'm like, well, the hip is not painful in the movements that I am
Mm-hmm.
taking you into, but
Right.
it's like, is it the driver? Maybe, but I don't. It's
Is it a
definitely not.
component
It's
of?
not
Yes.
moving. Exactly, it's not moving, and you have your mobility in your lumbar spine is good.
Mm-hmm.
Your joint mobility is good, and the fact that you overstretched, yes, that could have aggravated the pelvis. So I would agree with you that those symptomatic body parts are not the ones I would be treating. I would be treating, at least getting not directly from a manual perspective, but at least get the hip a little bit better mobility, and then work on getting him movement patterns out of that lumbar flexed, hip flexed posture. So, but I mean, he could easily cheat in lumbar forward bend and not flex his hip, which is what he was doing. Lumbar forward bend at the end of the day, his last visit was good. But I'm like, you're not flexing your hip. That's why when he got on all fours, I said, you're forced to flex your hip in that position. And if you want to just sort of mimic the lumbar flexion, just go into that rounded back posture and then sit, and you'll get it immediately, which he did.
Mm-hmm.
So I think he understood that. And he's like, that's why sitting with the book made me feel better. I said, yes. If you don't have a book, sit on a higher stool. Take
Mm-hmm.
one position out, take the hip out or take the back out, and you will feel better. So we'll see how he did up with the driving, because
Yeah, sounds
driving,
good.
driving is tough. So
Mm-hmm.
that is that. It's a short one, but I think he was acute. So I think this is a good exercise to go with, because he definitely had a lot of stuff, and it's good to make a differential with some of these acute people, especially at his age. So he's not old, he's young, but
Mm-hmm.
these people still working.
Yeah.
I think that's it. Thank you, everybody.
Okay. Thank you. And we will talk to you all at the next podcast.
Also, quickly, if you're going to leave, we've gotten such great reviews on iTunes that it would be great if you haven't reviewed the podcast on iTunes. It'd be great if anybody, you could leave a review. We would appreciate it. And for those of you who have left a review, we really truly appreciate it. We do read those, and it really means a lot to us.
Right.
Thank
And it
you.
also helps us get to more listeners.
Exactly.
So if you enjoy it, if you're learning from it, we're happy to provide this resource, but we want more listeners too, because we can get more engagement going forward. We have a couple of things that we're planning. If you're going to be at CSM, we're looking to do some podcasts with each of you. Let us know if you're going to be there and you'd like to hop on the podcast and talk about something that you're struggling with in your practice. That'll be a lot of fun. Also, stay tuned. We're looking to create a forum where everybody can jump in and perhaps discuss some of their tough to treat patients as well. And we'll keep you posted on that as soon as we have some things going with it.
Right. Thank
Okay,
you
Erica.
guys.
Thank
Bye.
you.